for Data and Analytics at VHHA. And today I have the pleasure of really kicking it off and co-presenting with our great vendor here and partner, which is HIDI, the Hospital Industry Data Institute. VHHA has worked with HIDI in various different capacities now for, I would definitely say, over a decade. And in that time, HIDI has handled from our data collection and processing services to more involved work, such as taking a look at our readmission rates on a statewide basis. And so I would say that about 7 years ago, HIDI started producing readmission rankings and reports for VHHA. These have been very popular with the Virginia membership, particularly because it allows some visibility using much more current data to hospitals to take a look at what some of the readmission rates are for their facilities, and then how that compares to both the state and to some other peers, within the Commonwealth. And so we wanted to put together this webinar today for the HIDI team to really walk all of our members that are interested through some recent changes in our methodology. And so today I'm joined by Christy, Brian, and Jamie from the HIDI team, and they are going to be walking us through some of these readmission measurements and updates. I will also mention Josette as well, who runs these reports, is also on the HIDI team. So sorry for leaving you out of the group there, Josette, but I just remembered. And I think now is a good point to turn it over. So I'm assuming it's either Brian or Christy that are going to take it from here.
Christy's going to take it from here. Thank you, David.
Thanks, David. All right, well, good morning, everyone. It's a pleasure to be with you today. As David mentioned, I'm Christy Hayner, and I'll be presenting on the VHHA readmission measurement updates and impact. I'm a data scientist with HIDI, and I'm joined today by my colleagues who David mentioned, but here are their pictures and titles. So Jamie is the VP who works closely with VHHA on their HIDI portfolio. Josette oversees clinical quality reporting at HIDI. I am responsible for the processing the readmissions data, and Brian is the program owner over HIDI's analytic solutions and development. So we are the team here to support you and answer your questions. We also have many others at HIDI working behind the scenes on managing your data and producing reports. David mentioned a little background, but here is the list of deliverables we provide around readmissions to VHHA. So we provide readmission PDF reports, risk standardized readmission ratio rankings, and 30-day readmissions limited data sets. All right, so our desired outcome for today's webinar is to make you aware of the upcoming changes to the readmissions methodology used by HIDI for your VHHA readmissions reporting, as well as understand the impacts of the changes on both volumes and risk-adjusted readmission rates. The changes will be implemented in the readmissions report starting with 2023 Q1 data refresh. So if you have any questions throughout the presentation, please put them in the chat and we'll be happy to address them at the end. And scope for today's webinar are high-level changes and impacts for the readmission measures listed there below. Describing the many detailed changes is out of scope, but we do have a link at the end and can provide it to you with the CMS specifications for you to learn more. We also are focusing on more general impacts. Hospital-specific impacts of the changes is out of scope. We, along with VHHA, are here to support you. So if you have any questions after seeing your reports, please feel free to reach out. Stroke is also out of scope for today because this measure was retired from CMS Inpatient Quality Reporting Program in 2019, and we did not update the measure specifications for it. All right, there are 3 types of changes in the update listed as rows here, and I'll walk through them. The first change was to update from the CMS 2017 specifications to 2020 specifications. This update mostly affected the inclusion and exclusion criteria for the readmission cohorts. The changes with expected larger impacts include slight decreases in volumes due to new exclusion criteria that supplements diagnosis codes with revenue codes for identifying admissions and transfers to rehabilitation units. These rehab-related encounters are excluded from index and readmission cases. And secondly, we expect and saw significant increases in COPD and pneumonia volumes, the index volumes, related to adding new diagnosis codes for inclusion in the COPD cohort, specifically those around chronic bronchitis, and also the pneumonia cohort, namely inclusion of sepsis primary diagnosis with secondary diagnosis of pneumonia as POA without a secondary diagnosis of severe sepsis as POA. The second change related to changes in HIDI's database used to source the readmissions data processing. So HIDI moved from sourcing its readmissions measures from a legacy database to its new analytic workbench, which was implemented in 2021. With improved patient identification and indexing using Novetta Entity Analytics. As a result, we expected slightly higher readmission volumes due to improved capture of readmissions to non-index hospitals. The third change relates to changes to the history file that HIDI made to improve alignment with the CMS methodology on risk variable capture, including restriction of encounters to those 12 months prior to the index. The change mostly alters the prevalence of several risk variables used as predictors in the multivariate models, which affects ultimately the standardized risk ratio for some conditions. All right, so the impact analysis that I'll be covering today included all data from calendar year 2022 Q3 reports for VHHA, which include index cases from this 3-year period from September 1st, 2019 to August 30th, 2022. Based on our assessment of the impacts in other states, we do expect the results you see here to be the same for more current data. The hospitals included are those with 25 or more eligible cases for each measure. 80 hospitals were included in one or more of the measures. All right, so here, now we go on to the impact, starting with the impact on volumes of index cases. So this slide shows the distribution of the differences in volumes of index cases between the prior and updated methodology by condition. The x-axes represent the percent difference between the updated and prior version, and the y-axes are the number of hospitals. As you can see, most hospitals had less than 10% change in volumes for AMI, CABG, heart failure, hip and knee replacement, and hospital-wide readmissions. You can see this in the charts, as well as there's a table down here that shows the percent of hospitals with less than a 10% change. We observed significant increases in the number of index cases included in the COPD and pneumonia cohorts due to those additional diagnoses that I mentioned previously. The median change for COPD, as you can see in the bottom right, for COPD was 37% increase in index cases, and for pneumonia, an 88% increase. Hip and knee, the THA and TKA replacement also had more hospitals with a decrease in volumes due to some new exclusion criteria. All right, the next 2 slides show the impact of the changes on the standardized readmission ratios, which are also known as excess readmission ratios. This metric is what CMS uses to measure a hospital's performance on readmissions relative to an average hospital with a patient mix similar to the focus hospital. So if a hospital performs better than average, an average hospital that admitted similar patients, its SRR will be less than 1. And if a hospital performs worse than average, its SRR will be greater than 1. So these scatter plots simply show the correlation between the prior and updated SRRs. If they were equal, we'd see a diagonal line connecting the corners of these rectangles, and we'd see all of the dots, which represent different hospitals, on that line. While we don't see perfect correlation between the prior and updated SRRs, and that sometimes the updated SRRs are higher than the prior and vice versa. The plots and the statistics do show moderate to high correlation between the SRRs based on the correlation coefficients, which you can see as the R's in the top right corner. They ranged from 0.74 for pneumonia to 0.90 for heart failure. And hospital-wide readmissions had the lowest correlation of 0.6344. Now, this chart also shows the impacts on SRRs, and I tend to prefer it personally than the scatter plots. They show the distribution of the differences between the updated SRRs and prior SRRs, similar to what we saw previously with the volumes. We see that the majority of the hospitals, 90% or so or more, have SRRs within 0.1 points for AMI, COPD, heart failure, pneumonia, HIPAA, and hospital-wide readmissions. And this is good news, particularly for COPD and pneumonia, because of those large increases in index volumes that we talked about previously. CABG showed more variability in impacts, which could be due to just smaller N's and thus less stable estimates, as well as impacts of the history file changes. And as you can see on the bottom right, the median delta or difference across all measures was around 0 and slightly higher for CABG at 0.02. So what this all means is that when we switch to the new version, most likely you're not going to feel a difference in your risk-adjusted readmission rates. All right, so in terms of key takeaways, the updates to the HIDI readmissions measures have a modest impact on VHHA hospital-level risk-adjusted readmission performance, despite increases in volumes for most hospitals. And updated HIDI risk-adjusted readmission measures are more aligned with current CMS specifications and better capture inpatient hospitalizations and readmissions. All right, so as a reminder, the changes I've just described will be implemented in your Q1 2023 reports. We have plans to update the specifications even further to 2022 specs as early as Q4 2023 pending data program approval. So although the 2023 specs have been released by CMS, HIDI's general policy based on experience has been to use the specs 1 year prior to the current version to allow CMS more time to test the newer methodology and apply any updates to their software, which we use. So major changes, as you know, just looking ahead to CMS specs between 2020 and 2022 include those related to COVID-19 and the risk variables. To minimize the impact of COVID-19 on these performance measures, CMS has removed COVID-19 index admissions, excluded COVID-19 readmissions from the outcome, added a new history of COVID-19 risk variable to the risk adjustment model, excluded 7 months of admissions as index admissions, those occurring during the first 2 quarters of 2020, as well as December, which is what is used for the readmissions occurring during the early part of 2020. They also reduced the look back period for use of claims in risk adjustment to less than 12 months for those patients whose 12-month period included any portion of the first 2 quarters of 2020. And then the second major changes relate to risk variables. CMS has added a POA algorithm to the risk adjustment methodology used to pull the risk adjustment variables from index admission claims. This is good news in that POA coding is really a logical reflection of patients' comorbidities. In addition, POA indicators help particularly in cases where a patient has not been hospitalized or had provider visits in the last year, or when the comorbid condition is relatively new. So this is especially useful for us because VHHA and HIDI do not have access to claims from provider visits. So this change results in models with better estimates of a patient's risk of readmission than models without POA. And HIDI will be finalizing, we're going to be finalizing our methodology for approximating CMS's methodology and testing impacts later this year. Right, so here is just a slide with a link, but you can reference the CMS measure specifications on the QualityNet website. And that concludes the presentation. So we're now happy to answer any questions that you might have.
Hey, this is Andre from VHHA. Quick question here. So it seems like a lot of, you did mention some changes to like exclusions for index admissions in the new CMS methodology, but it seems like a lot of the changes that we did see were the result of, diagnosis codes being added or removed. And, the overall methodology of readmissions only, I guess, being captured within 30 days from a general acute care facility to a general acute care facility, like all of that stuff is still the same, kind of thing, right? That's kind of a summary of what's been changed. Is that a lot of the change we're seeing is due to ICD-10 code exclusions and inclusions?
Yes, that is correct.
Okay.
The underlying methodology has not changed. Yes.
Got it. Thank you.
Mm-hmm. Good question. Any other questions? All right, well, I hope that was clear. If you have any further questions that come to you later, feel free to reach out to, I would say, David, if that's okay. And we'll be sure to answer any of those questions.
Looks like David is posting something in the chat.
Okay.
And we had no other questions in the chat so far, Christy.
Okay.
One thing that I will add, David mentioned that we will share the slides and he will share the slides and recording with everybody later this week. And one thing to note, as we've rolled the updated methodology that we discussed today out with other in Missouri, as well as with other partners that we work with, we honestly haven't had any, to my knowledge, we haven't had a single user that has come to us. I mean, they might have a couple of technical questions about the inclusions, but nobody has really notably what I would call felt the difference in something that came back that caused any kind of consternation. Obviously, the increased volumes are notable. If as a hospital you're doing quality improvement within an area, the increased, even if your performance isn't the same, the increased case volumes can give you a little bit more of a robust estimate of what's going on within those cohorts, and you can start to see some changes over time. But we haven't heard any comments so far that any kind of quality improvement work that might have been in flight experienced a trend break or anything like that. So more or less good news. The methodology has been updated, but it should, like Christy said, haven't had anybody that came to us and said that they could really feel those results at a local level.
Thanks, Brian.
Hey, one more thing, one more question, actually. This is Andre again from VHHA. One of the things that we were talking about when we were doing analytics training this morning with our members was about, the overall, I mean, obviously there is a point to the CMS methodology. There's the hospital readmission reduction program, which, penalizes, our members' bottom line, when they're not doing well relative to their peers for a lot of these 30-day readmissions. But obviously, there are a lot of readmissions, I guess, potential readmissions that get excluded. Like if somebody gets initially admitted to a general acute care hospital, but then they get readmitted within 30 days to a critical access hospital, to my knowledge, that's just not something that would be captured. And so I don't want to say, obviously, that's, like a deficiency or anything. We want to be consistent with what CMS is saying, but do you guys measure also readmissions outside of, I guess, the very specific CMS methodology, or would you suggest the association to kind of develop its own to just measure all readmissions? Obviously keeping in consideration using the same ICD-10 codes from the CMS warehouse, so we have a reference to start there. But if we want to capture like a specific hospital or facilities, all of their readmissions, whether it's, a 30-day readmission to critical access or, I don't know, some lower tier facility, is that something that you guys already measure just out of curiosity, or is that something you think we could do?
That's a good question, Andre. So included, so both the, acute care hospitals and the critical access hospitals are already included.
Okay, got it.
The ones that are excluded are long-term care, psych, and rehab, and pediatrics.
Got it. Okay, got it.
But I think, in terms of what we produce, what HIDI produces, you do have some. You can decide which types of hospitals you include or exclude.
Got it. That's
but
very helpful.
Yeah.
So it is up to us. Like if we wanted to, obviously we want to stay consistent, but if we came to you again and we're like, hey, can you actually include another readmissions file that are, we could, push to the members, but instead of it being the, 30-day readmissions from CMS, it's like, for general acute care and critical access, it's like, hey, you also have readmissions to psych or rehab. Like that is something you could run if we just tell you to turn it on.
Yeah, as long as, there's still, inclusion exclusion criteria applied
right
to the individual discharges. So, it may not yield many that, qualify.
Right. Okay.
We can look at that. Yeah.
Awesome. Thank you so much.
Yeah, the elements on the data spec that are coming in, I know that typically we have everything is built off of the UB04 spec that's submitted within your state. Now, one of the things that ends up happening that we've seen before at non-acute hospitals, sometimes what's populated on those is not sometimes the elements that you need in order to be able to match or to be able to fit the methodology. Some of those elements might be missing. So if they are missing, you have to make a decision about whether to include the data with its imperfections and capture a few more or not. Right. So it's kind of a case-by-case basis, Andre.
Very helpful. Thank you.
Absolutely, sir. Great question. Thank you.
All right. It does not look like there are any further questions. So feel free to reach out again if one comes to mind later. And it's been a pleasure to spend time with you, and thank you for participating. Take care.
Absolutely. Thank you, everybody. We hope the presentation was informative.
Very helpful. Thanks, HIDI team.
Thank you very much.
Thanks, Andre.
Bye-bye.
Have a great rest of the day.
Bye.
You as well.